Thank you all for coming. My name is Dr. Ruth D'Souza. My pronouns are she, her, and I'm the moderator of this really important conversation. I'm a brown woman wearing a bright pink, red, and orange jumper. Hope you can see that because I really love it. And purple lipstick with a view of a painting and a bookshelf behind me. My professional background is in perinatal mental health, migration and birth, and I also host the podcast Birthing and Justice, which you can find wherever you listen to your podcast. I'm a migrant to Australia and would like to acknowledge that Indigenous people have practiced ways of maintaining reproductive health for thousands of years on this land. I'm talking to you from the unceded lands of the Bunurong language group of the Kulin Nation, and I acknowledge all the lands across Australia that people are joining this webinar from. I'd also like to acknowledge First Nations people who are joining us on this webinar. This always was and always will be Aboriginal land. There are critics of the idea of the land acknowledgement who say that it centres the experience of settlers and erases the continuing violences of the settler state. Is it enough to acknowledge that land has been stolen without having a corresponding obligation to then clarify how we will account for, change, or do something about this thievery? Or are we merely saying, I stole the land, but I'm keeping it, as Vivek Shrayapatli counters in their poem, Indian? Is acknowledgement enough? I acknowledge I stole this, but I'm keeping it. Social justice or social performance? What would it mean to digest you and yours and blood and home and land and minerals and trees and dignities and legacies? To really honor, no. Show gratitude. No word for partaking in violence and progress. So I use this acknowledgement to show my active commitment to learning about decolonisation and sovereignty through being in relationship with traditional owners to decolonise and be a responsible and accountable guest in my various roles of researcher, educator, community engaged social justice activist, anti-racist health practitioner, and critical decolonial feminist, committed to generative and generous social relations. The Multicultural Centre for Women's Health is hosting this webinar as part of their Multicultural Women's Health Australia program. They thank the Australian government for their support and funding, which leads a national network of services with a shared commitment to the sexual and reproductive health of migrant and refugee women. Today, we're going to share knowledge about the issues most impacting our network members and the wider sector. Sexual and reproductive health is often deprioritised by governments, yet our presenters will show today that reproductive justice is central to achieving gender equality. For migrant and refugee women, girls, trans and gender diverse people, the structural drivers of gender inequality are compounded by systemic racial and political exclusion and disadvantage. International students and their partners are another group who are structurally excluded from pregnancy and termination services and often in need of financial assistance. The good news is that we can achieve gender, racial, and health equity by promoting universal access to sexual and reproductive health and justice. So let me say something about reproductive justice before I get to the lineup and telling you what's going to happen today. Reproductive justice comes from Black feminists. It's connected with other struggles for equality and social justice. It involves strategies to contest interlocking oppressions. It centers people of color, about building coalitions. It's an expansive, multi-layered approach focused on developing new ways to create pathways of radical resistance and strategies for change that incorporate diverse economic, racial, gendered, and cultural locations. Make sure you read the wonderful resource in the Multicultural Women's Health newsletter, which goes into a lot more detail. We have a very exciting lineup for you in this 2-hour webinar. We're going to begin with a formal welcome in a second from Dr. Nisha Coate, who's a board member of MCWH, and a speech from the Honourable Jed Kearney, Assistant Minister for Health and Aged Care. We're then going to have speakers on abortion access, reproductive coercion, and international students' access to sexual and reproductive health services. Each speaker will speak for 15 minutes, and then the audience will have an opportunity to ask questions. And we ask that you do this through the Q&A tab on Zoom. We'll be having a 5-minute break around 2:20 p.m, but invite you to take personal breaks as you need them. If you are on Twitter like me, I encourage you to use our hashtag #ReproJustice, Repro with a capital R and Justice with a capital R, and tag MCWH1978 or me during our event and post your reflections and thoughts. So it's my great pleasure now to hand over to Dr. Nisha Coate, who's the board member, who's going to open with some remarks. Thank you, Nisha.
Thank you very much, Ruth, for that very beautiful introduction and for explaining what reproductive justice actually is. Welcome to all of the panelists on this really important conversation that we're about to have. And I'm so happy to see so many people join this webinar. Clearly, it resonates with many of us, whether we work in healthcare or not. It's a great privilege for me to be here as a board member for MCWH and to be able to inaugurate this webinar. I think from the point of view of me being a migrant woman, I can identify with some of the issues that are going to be discussed today. It's even worse for those migrant women who, unlike me, may not have the ability to speak for themselves, may not understand the language, may not understand the system. And I think these conversations are very, very crucial to making sure that we look after those within our society who are in the most vulnerable places, in the most vulnerable positions. A society's success is measured best by how we look after the ones who have the least. And as a society, if we are going to call ourselves a successful multicultural country, we need to be the ones who take the lead in looking after all of the people who need care. Healthcare should never be linked with visa status, should never be linked with a passport, should never be linked with finances. Each of us as a human being, as an individual, is deserving of equitable healthcare, access to equitable healthcare, as well as the best possible evidence-based healthcare that we can get. If we value the lives of women, or we value the lives of those who are pregnant, then we should value all of these lives equally. It should not be based on whether that person has a particular visa or a particular passport. It gives me great pleasure to have all of you as company here, and I formally inaugurate and welcome you to listen to the minister, who will have some really important things to share with us, I'm sure. Thank you.
Thank you, Nisha, and thank you for being such an amazing advocate for our communities. It's now my incredible pleasure to welcome the Honourable Jed Kearney, Assistant Minister for Health and Aged Care, with us today. What a pleasure to have you here. I'll hand right over to you.
Oh, thank you so much, Ruth. But clearly, seriously, the pleasure is absolutely all mine. I'm thrilled to be asked today to speak on this webinar, and I am calling from Melbourne, my EO, hence the very messy background behind me here. And I am on the land of the Wurundjeri people of the Kulin Nations, and I pay my respects to elders past, present and emerging, and I look forward to a time when their voice is enshrined in our constitution. But again, thanks for having me. You're such an amazing organisation. The Multicultural Centre for Women's Health does incredible work. And I'd just like especially to mention Dr. Adele Madolo, who is making an enormous contribution, both in her day job and as a member of the National Women's Health Advisory Council, which I chair and which I'm very thrilled to have Adele a part of. I also acknowledge the amazing lineup of women you have today. I wish I could stay all afternoon and listen. Unfortunately, I have to dash off to other events, but I'm glad to see that this is being recorded. So Ruth, hopefully, if you can share the link to me when you do share that around, and I'd very much like to listen, especially to the panel discussion that's coming up. Nisha, thank you so much for your opening words. really that's what we're here about, is equitable access to healthcare. And as the Assistant Minister for Health and Aged Care, it drives just about every ounce of my efforts in this role. I've got to say, I pinch myself every day as a nurse who started out life nursing on the wards up at the Austin Hospital to find myself here now in this position, being able to hopefully influence government policy. It's something that really drives me every day, is equitable access. Dr. Sophie, we have Miriam Suha, Dr. Tran, and Ruth herself, of course, on the panel this afternoon. It's going to be wonderful. So, as you would know, I have a very great interest in equity of access, particularly for women to the healthcare system. Every single day that I talk to women accessing the system or not, I hear about the shortcomings that are there in traditional healthcare. I have used the term medical misogyny to indicate that, not that I don't think doctors or healthcare providers or anyone are misogynistic. That's not at all what I'm suggesting. I'm suggesting that there are built-in biases in the system that create barriers for women, that mean women get poorer outcomes from healthcare. So often women tell me that they're ignored, they're patronised, and that they receive less than optimal care. There are treatments or care pathways and care guidelines that are predominantly designed for the male physiology and simply ignore the enormous differences that women possess. And someone once said to me that a lot of our care pathways, and I'm acutely aware that we have lots of doctors with us today, but a lot of our care guidelines and pathways are designed around a 50-year-old white male from Pennsylvania. And they don't really account for women's pathophysiology, let alone the intersectionality of a different background or for our migrant communities. Really, it makes such an enormous difference when wonderful people like yourselves in the system who validate concerns and listen and make sure that women in particular are heard. For migrant women, for refugees, people who don't speak English, the healthcare system can just seem impossible. And it's something that we really need to work on. And cultural complexities surrounding reproductive health create even more challenges, both for women who need support and, of course, for the health professionals who really do want to provide that care. So the context is what makes today's discussion so incredibly important. It comes at a time, I think, when there is a real and renewed focus on gender equality. This year, the Albanese government will deliver the national strategy to achieve gender equality, to make Australia one of the most gender equal countries in the world. That is our aim. Earlier this month, we delivered what my colleague Katie Gallagher, the Minister for Women, referred to as the best federal budget for women in more than 40 years. And as the Assistant Minister for Health and Aged Care, it's my privilege to drive change in an area that I am very passionate about, women's health. Earlier, I mentioned having the great fortune of having Adele on the National Women's Health Advisory Council, which I'm proud to chair. And it's members like her who are committed, knowledgeable, and dedicated to improving Australia's health system for women and girls that what makes this committee, I think, going to be incredibly powerful. Together, we are considering the significant biases that exist in the system. Research now shows us this to be true. A lot of research is showing us the difference in outcomes between the sexes. And the Council is looking at gender bias in the system across 4 areas, which might be interesting to your discussion today. So we are looking at safety. So what is it about the system that can ensure a woman, when she accesses the system, makes her feel safe? Regardless of her life's experiences, she may have experiences of violence, of sexual violence. There may be family, domestic violence. There may be cultural and classical taboos that make it difficult for her to talk about her conditions. There may be all sorts of reasons why the safety context is going to be incredibly important up front. We're talking about research. We know that predominantly those areas that women experience, those health conditions that women experience, are often under-researched. There's a lack of resources that goes to those areas. And consequently, we don't have the evidence base there to properly treat and deal with issues that a lot of women present with. Also, recently you might have heard that the NHMRC made a ruling that 50% of their research funds go to women researchers. And we know that women researchers more often than not research women's health conditions. So we're hoping to see a great improvement there. But we're also leading a group from the council, which will be looking at what are the gaps in research, where do we need to focus, and how can we make sure that our research system and our researchers are researching those areas that are important to women's health. There is another subcommittee looking at access, care and outcomes. Access, as you would know, is incredibly disparate right across the country. And for some women, accessing culturally appropriate healthcare is almost impossible. And I've talked a little bit about outcomes. And of course, the last group we're looking at is empowerment. And this is empowering women to understand their bodies, to understand what's normal and what's not normal. If you are a woman presenting with pelvic pain, you know, to have a doctor tell you, oh, it's just a woman's lot. You're just going to have period pain and it's because of your hormones. And it's all a raft of reasons why a woman has pelvic pain. And to be able to acknowledge, no, actually, that's not right. And I know that. To be able to talk about your body. And I don't know, it might be interesting, Ruth, to hear from your panel about women from different migrant backgrounds knowing the appropriate terminology to talk about their bodies, particularly genitalia. You know, it's even in English, it's very difficult for some women to talk about their vaginas or their labia. And to understand their bodies, to know they have ovaries and to use the right words, or understand periods. It would be a very interesting thing to hear this conversation from your panel today. So they're the 4 areas that we will be focusing on, and we have some wonderful representatives who will speak up on behalf of a whole cross-section of our community, including our LGBTIQA community. So imagine if you are a trans man having to present with menopausal symptoms or heavy periods, and it would be extremely challenging. So a key part of our success, this is the council's success, will be our ability to reflect the everyday experiences of women and girls and the experts who support them, including your wonderful organisation, the MCWH. Other consumer groups, we hope to hear from academics, medical professionals and peak bodies. We'll be calling in experts from everywhere. One wonderful thing that has just filled my heart with joy since I started on this process is knowing that there are so many wonderful people out there who care as passionately about this as me, and who are experts in the field and who are doing the research and who are plugging away, even often without resources, to really make a difference for women. So I'm very excited about that. But one of the first decisions we made was to establish an online hub. Now, the hub will allow people with lived experience of the system that hasn't met their needs, and experts, and anyone for that matter, to contribute their stories and contribute their information to the council. From next month, more information will be available on the council's webpage about this, and we really hope that organisations like yours will help us promote it. We're working to make sure it's absolutely accessible to everyone, including culturally and linguistically diverse women. You'll be able to upload your stories verbally, in language if you have to. You can fill in a questionnaire. There'll be various ways that you can contribute your information and your story to the hub, and ultimately to the work that we're trying to do. Because at its core, the council really wants to make sure that health issues specifically affecting women and girls and their well-being receive the attention they deserve. So that is really something important to us. And of course, we will continue to implement the National Women's Health Strategy, of which I'm sure you're aware, and absolutely positive you had input into. So while we look to the future, work continues at a furious pace, I have to say, across different areas of the health system to better support the reproductive health of multicultural women. We are absolutely committed to ensuring access to reproductive health information, to treatment and services that offer options to women, to empower choice, to empower control in decision-making about their bodies, including contraception, pregnancy counselling, and access to termination services. This includes our commitment to providing support for sexual and reproductive health services through public hospital funding, through the MBS and relevant services, through the subsidy of medicines, including some contraception under the PBS. Another particular area of concern is the tragic number of stillbirths in this country. 6 babies are stillborn every day, and the National Stillbirth Action and Implementation Plan recognises that rates amongst some migrant women and refugee groups are higher than average. And so we are working really hard to reduce preventable stillbirths by 20% or more by 2025. Now, one important aspect of this work we're doing is to address equity gaps through specific and targeted strategies for high-risk groups. So, for example, we are increasing education and awareness of stillbirth through a cultural adaptation of the Safer Baby Bundle. This is something that provides information to maternity healthcare providers and to women and families about 5 elements to reduce the risk of stillbirth: ceasing smoking, surveillance of fetal growth restriction, awareness of decreased fetal movements, side sleeping, and improved decision-making around timing of birth. Very easy things that we can pass on to women that we know reduces the risk of stillbirth. And we're also funding support services for families who've had experienced a stillbirth tragically, improving the standards of care and increasing the number. And I know it's a hard thing to talk about, but it's really important for us to understand stillbirth, and that is doing autopsies on the little babies when they are born, stillborn. And this will improve our understanding of these tragic deaths. And lastly, and then I'll finish up. Lastly, we have, of course, the Senate inquiry into reproductive and sexual health care. That has come, their public hearings have come to an end. And I know many organisations and individuals put really thoughtful submissions to that committee. Thank you all for your contributions, and we're really looking forward to the outcomes and the recommendations from that. So I hope this gives you a little bit of an understanding of some of the work that we're doing in this space. And we're particularly interested and very grateful for your input, particularly around barriers faced by migrant and refugee women. So thanks very much for having me, everybody. I really look forward to hearing the panel, albeit having to record it and download it a bit later. But thank you, Ruth.
Jed, thank you so much for that breathtaking array of developments that you're involved with. And I think it must be because you're a nurse. I'm a nurse myself.
Yeah.
And we're all about getting things done.
Yep.
And making things happen. We're people of action. But I just had a couple of thoughts about what you had to say before we moved to some questions. And one of them was I set up a perinatal mental health service in New Zealand. I moved here from Aotearoa. And for me, a thing I didn't hear in what you said, and it might be there and I might have missed it because I'm trying to be such a good host. And that was, you know, we can give people language, but if we still have an unresponsive system, then it's very, very challenging. So just to give you an example, you know, about, say, learning vocabulary, what I found through working in a perinatal mental health service is that when people finally get the courage to talk to a health professional, because there's also the issue of pride, there's all kinds of barriers to seeking help, right? So often they're dismissed or their concerns are minimized, you know. And so you know, for me, my life's work has been about how can we make our health workforce much more responsive? How can we make sure there is no wrong door for women, trans, non-binary people when they finally find someone that they can relate to? So I just wanted to throw that in the mix because I kind of feel like it's our responsibility for cultural safety, not just the recipients of care to be doing all this incredible labor when it's a challenging circumstance for them anyway. But can I move to our first question? And you might have some thoughts about what I said, or you might not. So don't feel you have to respond either to that.
No. It's absolutely front and center of everything that we're doing, Ruth. It's the biggest issue. That's why I put safety up there, front and center, because so many women give up. You know, they get treated appallingly. They get told that there's nothing wrong, or you're being anxious, or, you know, or they're not understood and dismissed and moved off. So absolutely, that is the very crux. Every single woman has a story, and I can't imagine what it's like if you are a migrant woman who doesn't have the language, or you are in the LGBTIQA community, or like, I hear you. I really do hear you.
Yeah.
And we are really
and so you know, how do we have access to, but also through those services, so people keep coming back, right? And so very encouraging to hear your work. And oh my gosh, I'm such a talker, so I better stop and ask you the first question, but thank you for responding to that. So the question is, what levers are available at the federal level for making sexual and reproductive health services more accessible to international students, seasonal workers, who are a really, really critically important group, and other temporary visa holders, and how committed is the government to making this happen?
Yeah, we're looking very seriously at this issue, and it's come up time and time again in the inquiry, the Senate inquiry, and we are acutely aware of this issue, particularly for migrant students. Often they have to wait 12 months before, you know, they have private health insurance. They have to wait 12 months before they can even access any sort of healthcare, if that are the terms and conditions of their private health insurance. So if you are pregnant, I mean, you know, that's impossible. So we're very acutely aware of this issue. We think that this will come up through the Senate inquiry. It's one of the recommendations, and we're looking very seriously at dealing with that. The levers that we can pull federally, we, as you know, we are responsible for the primary healthcare system. So that is GPs pretty much. And the states run almost everything else, you know, mental health care, tertiary system, the hospitals, etc. So for us, it's really making sure that there is a safe place for them to go, to have a good conversation, that they could perhaps access early termination if that is what they want, through their GP, so medical terminations. And there's a whole lot of work going on around that, Ruth. I really don't have time to tell you, but there's a lot of work going on around accessing medical terminations and the terrible barriers there are to that in our primary healthcare system for anyone, let alone a migrant student. And then the other levers, we're having very serious conversations via the health ministers meeting about what the states can do to make sure that everybody is cared for through the tertiary healthcare system, if indeed that comes to the point where they need a surgical termination. So it's a really good question. We are looking very carefully at that, and we know that that is a gap.
Is anyone else still forgetting to unmute themselves even after all this time?
It's worse when you forget to mute yourself sometimes.
I know. I was telling the participants earlier that I'm very naughty because I multitask during Zooms. And one time I was vacuuming and I'd forgotten I hadn't put the mute button on. So thank you so much, Jed, for taking the time out of your day. Really want to wish you well, and thank you for the support you have for MCWH and for this incredible agenda. And it's really exciting, and we're all hopeful that it helps to address the larger issues of equity in our communities, and that we have a fighting fit and healthy Australia as a result. I didn't get to write down, because I was writing lots of notes, but you said something about being the best in the world for, what was it?
Gender equality. So this is right
being
across.
Best in the world.
We have a gender equality lens that we put over all the budgets that we do. It's Labor Party policy, and we try to make sure that we really look at it from a woman's perspective, you know, right across the board. And I think this budget was amazing in many respects, not just healthcare, but right across the board. So
thank you, Jed, and also just want to wish you well for the hard work that you do, to keep at it, and we're cheering you on.
Thanks.
And thank you for joining us today.
And thanks for all you do. It's great to know you're out there.
Thank you. Bye-bye. It's my pleasure now to introduce our next speaker, and I hope everyone's excited and enjoying themselves. For people who want to mute, I know there's a couple who've just joined us. On the bottom left of your screen, there should be a mute button, but we think we had automatically muted you, but I did hear a wave of music earlier. It's my great pleasure now to introduce our next speaker, and I've been hearing really great things about them, so it's really cool to be able to introduce them. And our next person is Dr. Ahmed Shahir Mohammed Sofi. Them, who is an abortion care doctor and advocate living and working in Garamilla, Darwin, where I think it's much warmer than it is in Melbourne today, where I've got my fire on. They are the clinical lead of the Pregnancy Option Service at Royal Darwin and Palmerston Hospitals, and the medical director of Family Planning Northern Territory. They sit on several abortion care and sexual and reproductive health committees, where they advocate for equitable access to affordable, person-centered and compassionate abortion care for all, using an intersectionality lens. Over to you. Thank you for joining us.
Thank you, Ruth. I'll just share my screen. Yes. Right. Hopefully everyone can see that now.
That's awesome.
Thank you, Ruth, for that introduction. And thank you, everyone, for attending today. My name is Shahir. My pronouns are they, them, and I've been asked today to discuss abortion care access amongst people who are migrants and refugees in Australia. On screen is me, a brown, non-binary person of Malay ancestry with long black hair in a ponytail with a red batik shirt. And in the background, there is a notice board with an Aboriginal artwork hanging. I would like to acknowledge the Larrakia people, the traditional owners of the land from which I'm calling from today. And I'd like to pay my respects to their elders, past and present. So I'll begin my presentation by sharing the story of Grace, who sought abortion care in Darwin. Grace was a cis woman of colour in her 20s in her first pregnancy, who sought care in the second trimester. She was born overseas, but moved to Australia with her family during primary school. She lived over 2,000 kilometres away, but was referred to our service because she was not able to receive care locally due to her gestation. We offered her a telehealth assessment, given her distance from our service. Grace lived at home with her family because rent is expensive and she's only casually employed while studying full-time. She was therefore worried that her family, whom she's afraid would judge her, would overhear the consultation at home. So she had to take the video call outside in a park in another suburb. At one point, the video call dropped off because she ran out of credit. So we had to continue by telephone instead. When we accepted her referral, she had to travel to our service alone as her partner was not able to afford the cost of travel to accompany her. The travel costs were large due to the need to travel at short notice to Darwin. But she was grateful that she had a Medicare card because that meant that her care in Darwin was publicly funded because she was worried that she couldn't afford the cost of the abortion otherwise. Now, as we reflect on Grace's story, it's important to realize that many pregnant people who are migrants and refugees face similar challenges when accessing abortion care in Australia still. Many are especially worried about the cost, which remain an important barrier. Abortion care can be especially expensive when it's not publicly funded and when it's not available locally. So how much is an abortion in Australia? Well, unfortunately, abortion costs remains a lottery based on where you live, the gestation when you seek care, and your visa status. When abortion is stigmatized in your community, pregnant people, including those who are migrants and refugees, may not be able to seek out financial support or emotional support from their family and friends, exacerbating their distress further when seeking care that's already expensive. So here is the cost of an abortion if you have a Medicare card at a not-for-profit clinic in Sydney. See how the cost increases significantly as gestation progresses. You can imagine many would struggle to come up with $500, let alone $7,000 at short notice. You would think that since 1 in 3 women in Australia will require an abortion in their lifetime, and that 1 in 4 pregnancies in Australia will end in an abortion, that there would be more public funding in abortion care. But unfortunately, the majority of abortion care in Australia still occurs in the non-government sector, and it still comes with these large out-of-pocket costs, even when it's subsidized by Medicare. Chronic disinvestment in Medicare means these subsidies are no longer enough to meet the operational costs of abortion provision. So primary care and non-government providers can't afford to bulk bill anymore, and so they must transfer the cost to the pregnant people themselves, who ultimately are charged significant gaps to ensure that clinics can remain open for everyone. If you're lucky enough to live in a state or territory where publicly funded abortion care is widely available, like the Northern Territory, SA, and the ACT, then you might not have to pay for the cost of your appointments or your procedures. However, for pregnant people on temporary visas, they usually face the highest costs for abortion care anywhere in Australia, as they are usually unable to access Medicare subsidies or publicly funded abortion services in most states and territories, except in the ACT. Here are the costs of an abortion if you're on a temporary visa at the same not-for-profit clinic in Sydney. Remember, providers are forced to charge these exorbitant amounts because governments unfortunately refuse to pay for the care for people on temporary visas. Note that pregnant people on temporary visas may have visa-imposed restrictions on their ability to participate in any paid work. They may only be allowed to work a limited number of hours a week, or they may be prohibited from paid work altogether. Either way, this could restrain their financial resources to pay the high cost of abortion care, making it impossible for many to access it without substantial financial support or fee waivers from service providers. Imagine having to source this much money, $8,000, when you're not able to work in the midst of a rental, cost of living, and energy crisis. Costs can increase further when a pregnant person like Grace has to travel to access care. And travel for many pregnant people in Australia is necessary if you live in an abortion desert, an area where suitable abortion services are not available locally. People who live in rural and remote areas and people who seek care in the second trimester are more likely to live in an abortion desert and are more likely to have to travel further and pay more for travel because services become increasingly centralized in major centers. I'll illustrate this with 2 maps. The first one is from Sphere, and it shows where GPs and pharmacists were prescribing and dispensing MS2-STEP in 2019. MS2-STEP are the combination of medications used in early medical abortion, which is the most common method of abortion in Australia now. The green, bright blue, and yellow areas represent areas where there are no GPs prescribing MS2-STEP, no pharmacists dispensing, or where areas have need of them. And we can see that the inequity disadvantages rural and remote residents the most, as they are more likely to need to travel for abortion care. This next map shows the 4 out of 5 public hospitals that pregnant people in the Northern Territory would need to travel to if they want a surgical or inpatient medical abortion, represented by the stars. If a person requires care after the first trimester, which still counts for about 10% of all abortions, then they must go to either Alice Springs or Royal Darwin hospitals, the green and the red stars. Although rare, less than 1% of abortions still occur in the after 22 weeks, where you require a specialized procedure called the feticide. In the NT, this is only available at the Royal Darwin Hospital, where the red star is. Bear in mind, the distances in the Northern Territory can be massive, and sometimes travel is not even possible because of heavy rains or because of storms. So for example, the distance between Alice Springs and Darwin is about 1,500 kilometers, and driving between the two cities can take about 2 or 3 long days. So how much is the cost of travel for essential abortion care? So this can be substantial because you have to travel at short notice usually due to the time critical nature of abortion care. So for example, a return flight between Darwin and Alice Springs for one person for next Monday for a week stay in Darwin is about $900. The cheapest accommodation I can find online with a private room and bathroom for 2 people for the same week stay in Darwin is about $800. Add to that the cost of food and any Ubers within Darwin, and the travel costs quickly become unaffordable for many people. The need to gather resources to fund this travel at short notice can also contribute to delays or outright denial of abortion care for many. Additionally, the high costs may force pregnant people like Grace to travel alone without a support person. Imagine how alone Grace would have felt during her time in Darwin. Why is it important for us to consider travel costs for abortion care? Affordable travel arrangements go hand in hand with affordable abortion care. We're unlikely to eliminate the need for travel for abortion care. Even if we address all of the structural barriers to early medical abortion access, there will always be a demand for surgical abortions and abortion care after the first trimester. Both require trained proceduralists who must meet minimum caseload requirements to maintain their proficiency. So this might not be feasible in smaller centers. So publicly funded abortion care policy must include funding for travel and accommodation costs required when abortion care is not available locally. Most states and territories already have such a scheme to subsidize travel, but we must ask that this include pregnant people on temporary visas as well. So to recap, access to abortion care remains inequitable in Australia, including for migrants and refugees with intersecting identities. Access is still a postcode lottery for many. For a pregnant person who is a migrant on a temporary visa, who lives rurally, who requires care after the first trimester, who must travel to a major city that is hundreds or thousands of kilometers away from home, who have limited economic resources, who's unable to speak or seek support from their family or friends because of stigma, who's affected by climate change and can't travel because of storms. The cost of essential abortion care without government support can be catastrophic. So what happens when you can't afford an abortion? Pregnant people who can't afford an abortion are forced to continue the pregnancy, are forced to birth at term, and are forced to parent when they don't feel ready to do so, or when they don't want to be parents at all. This is a violation of their reproductive autonomy. This is structural reproductive coercion and abuse, and it must stop. So what should we do? I always like to have a list of advocacy actions so we can focus our work. First, we need to call state and territory governments to provide publicly funded abortion care for all, regardless of visa status. Remind them that it is possible as we applaud the ACT, and call for the others to follow suit. We must also call for any arbitrary gestational limit to publicly funded abortion care to be removed. And we need to allow pregnant people to make health decisions that suit their needs at their own pace. We must ensure that states and territories have a publicly funded travel assistance scheme that subsidizes travel costs for pregnant people and their support persons when abortion care is not available locally. And this must include people on temporary visas. We must ask the federal government to collaborate with state and territory governments to achieve universal access to abortion care for all, including people on temporary visas. We know the federal government is capable of committing funds towards the healthcare of people on temporary visas where there is political will. And we point to their wonderful commitment to fund antiretroviral medications for all people living with HIV in Australia, regardless of visa status, since July 2022, as an example of this commitment. We need to remind governments that equitable access to abortion care is a public good that benefits the community. Research shows that abortion care can mitigate the impact of abortion denial on economic exclusion and poverty amongst women. Abortion care can be important in gender-based violence prevention, including in safety planning when a pregnant person seeks to leave a partner or a family that uses violence. However, more research using intersectionality approaches is required to develop a nuanced understanding of the determinants and impacts of equitable and safe abortion access for pregnant women and people who are migrants and refugees in Australia in their intersecting identities, including those with diverse sexual orientation, gender identity and expression and sex characteristics, and those with disabilities. A national task force on rights-based abortion care as a public good should be established to do this. I hope by now you're convinced of two things: that for us to improve abortion care amongst pregnant people who are migrants and refugees in Australia, we must ensure that affordable care is accessible for all, regardless of visa status. Secondly, I hope that you're convinced that this is possible in Australia. As I wrap up, you may notice I haven't touched upon several important issues listed on the screen, which I believe are overarching issues that are shared across all of the other topics in today's webinar. So I hope I can address them with the other speakers during the joint Q&A segment at the end. So I'll just finish off with Grace's abortion story. She received her care in Darwin by feticide and inpatient medical abortion, and she was accompanied by her care by the hospital chaplain, who provided support to Grace in lieu of her partner who couldn't be there, and in lieu of her family whom Grace didn't feel comfortable sharing the journey with. Grace spent time with the pregnancy remains after the abortion on her request and opted to have bereavement photos and footprints made and kept in her file so she can request them at a later date when she feels ready and safe to do so. She traveled home after a week, and a week later on phone follow-up, she expressed immense track with her life plans. Thank you.
Thank you, Shahir. What a stunning presentation, and so impressed also with the ways in which you encouraged those of us that were watching with a call for action, because I think often when we hear the scale of the issues, we can feel a bit powerless and lost. And I really love how you ended the presentation with some calls to action and things that we can all do. We've actually got a little bit of time for questions, and I wondered if I could ask you one before we have our break. And we're then going to have a break, move on to the two next speakers, and then we'll have a joint question time and a bit of a conversation between us. I was kind of wondering two things really. The first one was, what can people do that are community engaged that are watching this? So, you know, aside from these, you know, you talked about structural reproductive coercion, you know, and your strategies are very clearly about tackling those bigger ones. But I'm just sort of wondering, what are some things that people can do in their kind of ordinary lives to encourage their friends and support networks? Because for lots of them, right, they're not going to necessarily know how to navigate the system. So what can people do who are watching this right now if they want to facilitate knowledge, access, and so on? Do you have some tips?
Thank you for that question. That's a really good one. I think the biggest one is to try and counter abortion stigma within the community, because that's still a big determinant of safe access to care, and it's a structural determinant of funding of abortion care as well. And so I think my recommendation is for people to learn more about abortion care and to read widely about the experiences of people who have had abortions, especially with intersecting identities. Read about refugees and migrants who have had abortions and people who are gender diverse. I encourage people to look up the Turn Away study and the book that came from that large study. And that was a study based in America that looked at the socioeconomic outcomes of people who have had abortions. And it was a very useful study to counter a lot of those stigmatized beliefs around the poor mental health outcomes of people following abortion. And it clarified the benefits of providing rights-based abortion care and how abortion denial causes poverty. Abortion denials lead to prolonged unemployment and underemployment amongst women. And it also has all of these narratives of the people with lived experience with abortion care set in America, but I think there are sort of lessons that we can gain from reading that book. So that I encourage everyone to look that up and to have conversations with each other to see, because it's more common than people think. One in what did I say before? 1 in 3 people would have had an abortion in their lifetime. So many people don't talk about abortion because no one wants to. But I find that with my friends who have capacity for pregnancy or have been pregnant before, once they start talking about their abortion experience, people open up and people start talking, oh, I've had an abortion. I've had an abortion. So we need to do that. We need to do that with our friends, with our co-workers, if we're comfortable enough, with our families as well.
Thank you. That was a fabulous answer. And we've got one more question from the audience for you. And it's from Zoraida, she, her. And I hope I said your name right. And she says, what is the pathway to access abortion services for someone on a temporary visa? And she says that people usually have private insurance, but she doesn't think it covers abortion services.
Thank you for that question, Zoraida. And I think with the next one of the next speakers will talk about international students and sexual and reproductive health, and I think that would be very pertinent as well. Okay. Around private insurance and whether that is covered. The short answer is it depends on the private insurance itself and the type of care, whether it's outpatient based or whether there's an admission required. And sorry, I just there's a child in the background screaming.
Keeping it real.
Yeah. So because of the varying types of private insurance, most clients would need to navigate that. And that is one of that I think as abortion service providers, we need to help clients navigate that. It's not enough for us to just say, ask your insurance providers, because it's just a quagmire of like systems, and that will delay things. But where people have private insurance, they have to check with their private health insurance providers. Otherwise, some people might not be comfortable using their private insurance if it's linked to a family account, or if their parents are paying for the private insurance as well. So sometimes it is out of pocket. In our service, in the hospital, we make payment plans for the clients so they can access care without having to pay upfront. And in some cases, we apply for a fee waiver on their behalf in very extraneous, in dire circumstances. Yeah.
Shahir, you've been incredible. Thank you so much for making such a large topic and such a complex, painful, difficult topic really useful, relevant, relatable for us all. And I think what I'm going to particularly take away from myself is around about those structural forms of reproductive coercion, you know, and those bigger structural determinants. I live in a regional area, and you know, it's a smaller scale than what you're talking about, and maybe that's something we can all take away and advocate for. But also, thank you for giving us some hope and some ways in which we can make a difference to the amazing work that you're doing. So, bravo, thank you. We're going to now have a break, and hopefully you can go and put the kettle on, have a nice little cuppa, and we're going to be back here at 12:30. I hope you're all kind of learning some new things or coming away with some ideas or strategies. And we're now on to the second half of our webinar, and we've now got the amazing Mariam Suha on the topic of reproductive coercion. So it flows really well from the presentation we've just had. Suha, who's a she and her, who identifies as she, her, is an experienced researcher and has worked on various research projects relating to reproductive coercion and violence against women. Her previous experience includes working as research assistant on the Muses project, which stands for Multicultural and Settlement Services Supporting Women Experiencing Violence, funded by Anne Rose. Suha is currently a PhD candidate, yay, at the School of Geography, Earth and Atmospheric Sciences, University of Melbourne. Her thesis explores the intersection between masculinities and migration as an adaptation to climate change. Over to you, Suha.
Thank you, Ruth, for the lovely introduction. And I am very excited today to share my findings from a paper that I produced with a few colleagues on reproductive coercion. So to begin, I will just share my screen. So today I would like to present about experiences of reproductive coercion amongst migrant and refugee women in Australia. Before I begin, I would like to acknowledge the traditional owners of this land, the Wurundjeri people of the Kulin Nation, and pay my respects to elders past and present, and recognize that sovereignty has never been ceded. I would also like to take this moment to acknowledge that as a queer refugee migrant living in Australia, the way that I am positioned to benefit from the ongoing displacement of Aboriginal people and the colonization of Aboriginal land. And just to quickly provide a description of myself, I am a woman with tan skin and long black hair wearing a green turtleneck, and my background is blurred. And before we begin, I would also like to just put it out there for the audience that some of the content that we will be discussing includes discussions of graphic sexual violence. And so if this is not for you, I will make sure to also provide this content warning again before we dive into the more graphic details of these experiences. So what is reproductive coercion? Generally, it refers to patterns of controlling and manipulative behaviors that interfere with the autonomy of a person to make decisions about their reproductive health. And this includes behaviors that can range from control of contraception to forced sterilization, and pressure to conceive or controlling the outcome of a pregnancy. While reproductive coercion or reproductive coercion and abuse is often described as a form of gender-based violence, it is important to recognize that reproductive coercion can occur beyond the bounds of heteronormativity. However, for the purposes of this presentation, I will be talking about the reproductive coercion and abuse experiences of migrant and refugee women. Reproductive coercion often occurs in the context of violent intimate partner relationships and alongside other forms of intimate partner violence and sexual abuse. What What characterizes and differentiates reproductive coercion from other forms of sexual violence and gender-based abuse is the use of fear and manipulation with the intent to control reproductive choices and bodily autonomy. To this end, perpetrators of reproductive coercion and abuse can include family members, other groups, and state. For example, a very notable instances of state-endorsed structural reproductive coercive violence includes, for instance, Australia's migration policies from the end of the Second World War, and notable cases in living memory from Manus and Nauru. When we talk about reproductive coercion, we're also talking about the structural and institutionalized forms of discrimination like gender inequality, racism, and ableism that enables the perpetration of reproductive coercion and abuse. And we cannot think about reproductive coercion separate from these broader structural issues that position migrant and refugee women in vulnerable ways. And so today I would like to present the findings from data that we collected for the Aspire project. Just very briefly to provide a little overview of the Aspire project, which wrapped up in December 2020. December 2016. This project investigated violence against immigrant and refugee women in the southern Australian states of Victoria and Tasmania, and broadly looked at the dynamics and contexts of women's experiences, help seeking, use of knowledge and services. 46 in-depth interviews were conducted, 33 in Victoria and 13 in Tasmania. While the focus of this research project was not reproductive coercion, what we found going back through the data is instances of reproductive coercion that we now recognize as reproductive coercion. So before I move on to providing snapshots of the lived experiences of migrant and refugee women, I would like to reiterate again that there will be descriptions of graphic sexual violence. And so please note that. So some of the examples we found include violence during pregnancy with the intent to end the pregnancy. So this is the story of Celine. When I was pregnant, 6 months, he wanted to kill it with a stick. He doesn't want a baby. That day he wanted to snap my stomach. What I did, I put this knee straight like this to my stomach, and my knee broke. Celine's story demonstrates how reproductive coercion and abuse can occur alongside other forms of violence, like physical violence. Another story of violence during pregnancy with the intent to end pregnancy was that of Katie. Her story goes something like this. I was happy even though it was not expected, and we were trying to control it so that I didn't fall pregnant, but it's happened. My husband came home 2 or 3 days. He did not really speak to me. We started fighting. I was standing and he said, "You want to lose the baby? I don't want the baby. My mom said that we are too young to have a baby. How will we cope?" I said, "My parents will help me. I have milk." He said, "You will lose this baby. I will make you lose this baby." He pushed me on the bed so hard and I felt it in my tummy. I started crying, but he didn't come and hug me. The next morning, I started bleeding. We also came across situations of forced pregnancy. This is Julie's story. The honest truth was that I never really wanted to get pregnant. I suppose to an extent, it was sort of, I don't know why I'm saying this, to an extent, he forced himself on me. I was working and he started to get a bit insecure. Then it was, you need to get pregnant. And it sort of started from locking me in my room, trying to get me pregnant. The idiot popped them all out. I used to take the pill and I used to hide it, and he found it and popped them all out of their packaging, fed them to the chooks. I couldn't leave the room, like literally betting myself in the corner of the room because I couldn't get out. He locked me in there all day. He wanted to keep me there. He wanted to keep me at home. If I was pregnant, I wasn't going nowhere. Who's going to want her with a child? She'll never leave. Here we see in Julie's case, Economic empowerment and financial security may also be triggers for the onset of reproductive coercion and violence. We also came across situations of forced abortion. As Bharti described, I got pregnant in July. Then he forced me to have an abortion. My husband rang partner's mother to help take me to the hospital, but he didn't want to go with me. He was not with me at the time. Partner's mother did everything. She took me to the hospital and she stayed with me at my place for 2 or 3 days. The next day, he just went to the gym. He doesn't care. This particular example illustrates a particular facet of the experience of reproductive coercion and abuse among migrant and refugee women, which is that that this violence may be perpetrated by multiple perpetrators. Another example of forced abortion is Mannat's story. My sister-in-law gave me the test and said if I was pregnant, I had to have an abortion. I told her I'm not going to abort this child. It was my child. I told her I couldn't kill anyone, so she started punching the wall. She was the dominant person, so I was afraid that without her permission, she would stop the baby. My husband didn't listen to me, and I cried the whole night. So she, sister-in-law, booked an abortion and made an appointment. I was crying and saying I could go back if they couldn't afford the baby. I'd go back to my country and stay with my parents, but I couldn't kill my baby. He didn't listen. For the confidentiality, they had to take a signature, and they took me in the room. I said I wasn't going to sign, but my husband said I didn't know English and he understood a bit, so he accompanied me to sign it. I was too scared to tell them that I did speak English because the choking, hitting, and abusing was too much. In this particular case, we also see that perpetrators can accompany women to abortion clinics and to doctors' appointments. And the result of all these experiences that we uncovered was that what we understand from that is women from immigrant and refugee backgrounds may not present as typical cases of intimate partner violence. Extended family, including other women, may be complicit in coercing women's healthcare decisions. And most importantly, structural inequality embedded within the Australian health system means that immigrant and refugee women face additional barriers to accessing reproductive health. So where do we go from here? Because reproductive coercion is a relatively new field of research and there's still so much to find out, we recommend that more information is needed about the interactions between health services and migrant and refugee women experiencing reproductive coercion and abuse, and how vulnerability to multi-perpetrator violence affects health service access. We need to know how to conduct appropriate prevention and advocacy work about reproductive coercion and abuse in refugee and migrant communities that are non-stigmatizing. We also need to know what training is needed for professionals in the family violence sector, women's health services, women's organizations, and multicultural and ethno-specific services so that migrant and refugee women experiencing reproductive coercion and abuse do not fall through cracks in our system. And this is the reference to the paper from which I draw all these quotes. Thank you very much.
Suha, thank you. What important work you're doing, and you know, those quotes are so powerful and heartbreaking. And just want to acknowledge that if there's anyone who's watching and listening whose life's been affected by reproductive coercion, just go gently and do something kind for yourself right now. Please feel free to add some questions in the Q&A. I know you're all very shy, all 110 of you. But Suha, I'm kind of wondering, from this initial work, you've talked about ways forward. Are there some clear things that people can do? And I guess this relates to the question that I asked earlier, because sometimes we can hear stories like this that just break our hearts, you know, like I was like crying, you know, like just feeling so sad for the people that you talk to, and of course we know there are plenty more, right? What kind of things can we be doing? And I guess I'm thinking, I'm also thinking about primary prevention and you know, the kind of relationships work that can happen. But have you got some sort of top up kind of thoughts about what people can do? What are some tangible things people can do that are watching this?
Thanks for the question, Ruth. That's a really good question. Some of the tangible things that people can do, first and foremost, is to have conversations around reproductive health and sexual health, and to dispel the myths around the mechanisms through which these forms of violence occur, and especially to focus on the way gendered systems of power and relation affect how we access sexual and reproductive health services, and also understand our sexual and reproductive health rights.
Yeah. There's so much in there. I just want to I just want you to keep talking because you know, I know that there's a lot more you can say. So you know, let me talk about workforce, because that's what I'm particularly interested in, because so often our strategies, particularly in neoliberal systems, they pass on the burden of work to the consumer or the end user. You know, what's the work that health professionals should be doing? You know, like my field is cultural safety, and, you know, the fact that I've been doing it for 30 years shows you that, you know, there's still work to be done. So, you know, if people can't even do the basics in terms of creating culturally safe environments, what can they do in this space? You know, like I kind of despair about it, but what kind of proficiencies, what kind of capabilities can they have? Are there questions people can ask? You know, how might they intervene? Do you have any thoughts about that?
Yes, in a professional capacity, there are lots of things that we can do as individuals who care about this issue and who care about migrant and refugee women's health. And first and foremost, it would be to recognize the ways in which sexual abuse and violence and gender-based violence and reproductive coercion and abuse, how we come across that in our lines of work. Do we come across it? In what ways? And how does it manifest? And how are we placed to then respond to this? And the second most important thing that we can do right now is advocate for the rights of migrant and refugee women and elevate their voices as agents of change.
Beautiful. Thank you, Suha. You've given us so much to think about. And I also think that what you're kind of demonstrating is about more than inclusion. It's also about leadership. So I really appreciate that. We're now going to go to our next speaker. What a lot of wonderful people we've had speaking today, who is Jiang Tran, who identifies as she and her. And she's going to be talking about international students' access to sexual and reproductive health services. And somehow I've lost her bio. Here we go, here it is. Jiang is a research advocacy and policy officer at the Multicultural Centre for Women's Health. She's passionate about migrant and refugee women's health issues and works to increase migrant and refugees' opportunities for health and well-being. Dr. Jiang has a range of experiences in qualitative research, evidence synthesis and knowledge translation, and has worked on issues such as migrant and refugee women's mental health, exploring women international students' experiences of sexual violence, intimate partner violence, and access to support services. It's so great to have you here, Jiang. Thank you. Over to you.
Thanks so much, Ruth. Hi everyone. I am shown as a woman with short hair, wearing glasses, and blurred background. So let me share my screen first.
We're all being very good at sharing screens, so technologically proficient, aren't we?
I'm going to share it. I don't know where. Oh my, here. Let me share it again. Sorry.
Take your time. We can focus on our breathing while we're waiting, which we never have time to do. Beautiful. We can see that, and you're going to put it on slide view for us. Beautiful.
Yeah, thank you very much. And in my presentation today, I would like to share the difficulties of in accessing health care services of international student women. So just wanted to note that in my presentation, there will be mention of violence against women, but it is not in a graphic detail, and it is only in reference to our research. Before I start, I would like to acknowledge the traditional owners of the various lands of which we are all zooming today. I'm zooming from the unceded land of the Wurundjeri people of the Kulin Nation, and I would like to pay my respects to their elder, past and present. So in my presentation today, I would like to share screens. So I would like to, I will be starting by giving a brief background about international students, the coverage of health, of overseas health care insurance, and the current issue of international student women health. I will then spend most of my time to discuss the barrier of accessing healthcare services of international student women after experiencing sexual violence and intimate partner violence. In the last part of my presentation, I will offer our recommendation for improving access to healthcare services for international students. So it should be noted that in my presentation, I will discuss some of the key findings of the INVEST research project, which has been recently collaborated among Multicultural Centre for Women's Health, the University of Melbourne, Monash University, Deakin University, and the Immigration Women's Support Services. I also add on advocacy lens to these presentations. So I understand that this is limiting and not always inclusive of non-binary and gender diverse people who may experience significant barrier to accessing healthcare support and also experience both sexual violence and intimate partner violence. So the participants of the qualitative part of the INVEST project were mainly cisgender women. So for the international student in Australia, in 2022, we have over 600,000 international students studying in Australia. So as mentioned earlier in the other conversation, previous conversation, so for all international students in Australia, a condition attached to their visas is to purchase overseas student health cover for themselves and for their dependents to cover medical costs for their duration of their stay in Australia because they are not eligible for Medicare. So although the private insurance cover basic medical treatment for them, for international students, the restrictions on pregnancy related to costs within the first 12 months of arriving in Australia and the gap between the coverage of OSHC and upfront fee have resulted in limited reproductive choice and significant barrier of accessing healthcare support. For example, when international student women who have unplanned pregnancy within their first 12 months in Australia are forced to pay out-of-pocket costs for their antenatal healthcare if they want to continue or terminate the pregnancy. In addition to that, some of the private insurance left many international students who have babies to cover their own antenatal and multinatal healthcare costs. So the current Australian research show that there is a high rate of unintended pregnancy, sexually transmitted infections, poor access to healthcare services, limited sexual health literacy among international students. And also international students in Australia have been identified as a population that appears to experience high rates of sexual violence and intimate partner violence. So from the existing literature, little is known about the lived experience of international student women who suffer from sexual violence and intimate partner violence. They have seeking strategy and they support needs. However, what we do know is that risk factors leading to the issues are structural and systemic discrimination associated with migration and international student status. This intersectional disadvantage put many international student women at risk of experiencing sexual violence and intimate partner violence and prevent them from accessing healthcare and support services. So as mentioned earlier, I'm going to give a very brief overview of the qualitative parts of the INVEST project, which has been designed to explore help-seeking experience of international student women who experience sexual violence and intimate partner violence during the time of studying in Australia. So from August 2021 and June 2022, we spoke to 30 international student women from 16 countries. So also here is a list of our research team of this part of project. So we are also in the process of publishing a paper on the issue as well. So overall, we found that the participants experience complex and significant challenges in seeking support for their health and safety after having sexual violence or intimate partner violence. So in this, in the next slides, I'm going to share three main themes of barrier in accessing healthcare service, including socially isolated from healthcare system, inaccessible and unaffordable healthcare services, and limited culturally and linguistically responsive support. Firstly, being socially isolated from the healthcare and service system had been found one of the significant barriers to access. Many participants said that when things went wrong, they knew nothing about where to go and what services were available for them. For example, in the first interview is I can't find anything around me. It is hard as an international student. Being thrown into a new area, you have to learn everything around you. So when I asked her, have you ever tried to book GP? And she answered like, I didn't even know about GP until you just told me about it. So the participant came from an English-speaking background. So we could see it was still very difficult for her to navigate the health system and seek help for her health after experiencing sexual assault. So for international students from non-English speaking backgrounds, the added barrier of language and communication might add more challenges for the student to find and access local services. So in the second interview itself, this student experienced internet-made partner violence and had to manage the symptom and diagnosis of a sexually and transmitted infection. And she said that I'm here alone by myself, honestly, don't know who can talk this to. It is that very difficult. I can only search online, what can I do? And I don't know where to ask. I don't know what the resources are and which platform can be used to seek help. So in other part of her interview, she disclosed that she had to deal with everything alone with limited support because she had no one to lean on for support or information. She had tried to manage the sexually transmitted infection symptom by looking for sexual health information online, and she was extremely anxious and scared at that time. Finally, she decided to look for a sexual health clinic to get tested for the first time in her life. So what I'm trying to analyze and say here is that the lack of familiarity and knowledge of the healthcare and support service in Australia result in the inability to link in and to connect with local services. So as a result, the participant either deal with the health issue alone or delay seeking support for their needs. Secondly, I'm going to talk about issue on inaccessible and unaffordable support services. During the interviews, our participants were overwhelmingly described the costly services, long waiting time, and the lack of university support when they need support for their healthcare and safety during the tough time of sexual violence and intimate partner violence. These are two quotations from the endless conversation of almost all the participants around this issue. For example, in the first interview is she said, I don't feel Australia cared about me or has any concern about me, or the services are not available for me. I'm struggling to pay my simple account, my simple bill. I need time of support to make my life work. So this student suffer from sexual and financial abuse from her partner, who was also her boss at her workplace. So he had unintended pregnancy, gave birth, and was raising the child on her own. At the time of her interview, she was living in a shelter and in an extremely hard situation of financial stress after a long and complicated journey of seeking support from Centrelink, legal services, domestic violence connect services, and health professionals. And in the second interview, the participant experienced sexual assault. She went to see her GP, but did not proceed with mental health support because it was too expensive, as she said. I have overseas health insurance. I pay $150 a month for, but still I have to pay $200 for mental health care. I've seen so many of my friends say that like, I can't afford it. I'm not going to go. So they are just suffering because it is too expensive or because the waiting list is up to a year. So our finding reinforce the issues with not having to universal access to healthcare. This critical issue has been raising for more than a decade. In Greece, migration visa status and international student insurance policy create challenges and hardship for those who are seeking sexual and reproductive health care and for international students who experience sexual violence and intimate partner violence. So, and the third issue I would like to share is the limited culturally and linguistically responsive support. Almost all participants share their preference and the benefit of being connected to social worker and health professionals who are from similar cultural background, whether that were in Australia or outside Australia. For example, in the first interview, this participant disclosed that she had spent almost 1 year in an abusive relationship and suffered from mental health issues. After facing difficulty of accessing healthcare service in Australia, she chose to go back to her country to look for an Italian psychologist. As he said, I seek help in Italy. Thus, because here I'm a bit lost in a matter of who I can talk to. I would rather speak in Italian because I can express my feeling in a better way than speaking English. So in the second interview, the participant talked about her experience with her GP doctor who came from different cultural background. So as he said, sometimes when you talk with someone in the clinic with a similar cultural background as yourself, it's not going to be that challenging because there is a way like culture difference. When you try to explain something that's normal in your culture, the doctor may feel that it's very different or that's a problem. So the doctors focus on the other things rather than what your main concern is. So in her experience, the doctor misunderstood her medical issues and instead tried to treat something else. And that wasn't a medical problem, but a reflection of differing cultural practice. So this experience not only shows that cultural background and language are important factors for international students when it's come to accessing support that is tailored to their needs, but also highlight the systemic racism and discrimination in healthcare system had prevented many of the students from moving forward to seek support for their healthcare that they need. So in MCWH, we have been working to advocate migrant and refugee women, and including international student women. So the issues of accessing healthcare service has been raising for almost over 1 decade, and the problem's still there. So how can we eliminate the barrier and make the healthcare service more accessible for international students? So we believe that everyone have a role to play. Whether you are a health provider, researcher, or policymaker, there are actions you can take to better exercise your duty of care to international students. So we recommend that international students have access, clear guidance about the availability of healthcare and support services while studying in Australia. International students have universal access to healthcare services while studying in Australia. And healthcare and support services, both within educational institutions and the broader community, are culturally and linguistically responsive for international students. And support services workforce reflects the diversity of population in Australia. So we can't have reproductive justice and gender equality if we neglect international student access to the healthcare that they need during the time of study in Australia. So thank you for listening.
Thank you, Jiang. What a comprehensive and interesting presentation, and also deeply worrying, because there's a lot of people who are missing out and who need the support. Can you hear me okay?
Yeah, I can hear you.
Okay. I was just checking if there are any questions for you. People are being very shy today, but luckily I always have a question or two up my sleeve. What do you think the next research is going to be for you? You know, you've done this work, and it said you love research. What are the kind of early questions that are coming out of this work that you might want to continue to follow up?
Thank you for the questions. I think in literature review, it had been absent the voice of women international students, even in general, and even they experience sexual violence and intimate partner violence. So no one talk about that, and the issues are still there. And when the sample of the research is very small, you can see that only 30 voices we heard from Queensland and Victoria. And the findings, we actually have found a lot of issues related to safety and healthcare for them in Australia. But in this presentation, I presented accessing services. And one of the other things we have found in the research I might say here is the students kind of prefer help seeking for the informal support rather than formal support. And they maybe went back to their country at the example. So that maybe present an issues of healthcare system here is not available or inaccessible or unaffordable for them to accept and to seek help and support when they need.
Yeah, and related to that, Jiang, what do you think the responsibilities of universities is? Because, you know, speaking as an academic myself, you know, we take their money. What is our, you know, did your research have some implications and recommendations for universities and the work that we should be doing?
Yeah, in university, I think they have the service for international students, definitely. But it had been said that the service is not really culturally and linguistically responsive, and maybe as you said, mentioned in the previous conversation, and it's not safe. And the women try to share their story, and in terms of sexual violence or intimate partner violence, it's a lot of stigma, and they don't want to share. And my participant said that I couldn't find anything around me, and she's at the enter to the university. And for many of them, maybe university support or service is the first place they look for when they have when things went wrong or they have issues. But unfortunately, a lot of participants in our research share that they couldn't connect and they couldn't find it helpful for them when they seek help.
Oops, forgot I was muted again. That is really sad. We've got a lot of work to do, us universities and people that work in them. Jiang, thank you very much for giving us so much to think about. And oh, there's a comment here in the chat. while the others are coming on, I'll just mention it. It says educational institutions are not providing enough information to students. For example, language schools, who are the main recipients of international students, don't inform students about the services or rights. Very good point. Thank you very much for that. We're coming up to the end of our webinar, and don't go yet because it's going to get really good. The best is yet to come. So I'm really privileged to have these gorgeous people who've shared their knowledge and passion with us. And what I'm going to do, just to wrap up for us, is kind of ask them to reflect on what other people have said, what the questions have been, what the chat have, what the chat sort of generated, and just ask them for some closing words. I'm going to ask the speakers for their reflections, final thoughts, and calls for action. So maybe what we'll do is we'll start with Shahir, go to Suha, and then Jiang. Is that a good order in which to go? And I'm just going to give you roughly 5 minutes, or less. Less is always good because people love finishing webinars early and never finish early. So we could be amazing too.
Thanks, Ruth, and thanks, Jiang and Suha, for their respective talks. That was amazing to hear from such brilliant researchers. As a practitioner, I feel like I'm out of depth with these academics. So my final thoughts on today was we can see the interconnection between abortion care, reproductive coercion and abuse, violence, and how migrants, especially those who are on temporary visas, how all of that is connected. And when in my talk, I listed a number of issues that I didn't touch upon, but luckily Jiang did in her talk. And those issues around cultural safety, on having multicultural or bilingual health workers are so important, especially within the space of sexual and reproductive health. And I think we need to figure out, how do we get people from migrants and refugee backgrounds to be involved in sexual and reproductive health care? How do we get health workers involved in our sector? Because there is still a lot of stigma around sexual and reproductive health, and health workers from migrants and refugee backgrounds will carry that stigma as well. And I know, as an abortion care provider who's from a migrant background, I experience abortion stigma, and my family doesn't know that I'm an abortion worker, for example, and it's not something that I can talk to my family about. And it causes a lot of isolation, and it prevents people from wanting to join our sector. So we need to think about, how do we empower our workforce, because we know that migrants and refugees, especially women migrant refugees, are overrepresented in the care industry and the health industry. So we need to try and get all of those people into the sexual and reproductive health sector and provide this culturally safe service, especially for new migrants, for refugees and international students. I also wanted to sort of just highlight what Suha was saying about the nuances of family violence in migrant and refugee groups and populations. And from my experience as a provider of abortion care, we see how the fear of reproductive coercion and family violence is particularly important amongst migrants and young children of migrants who are so afraid of their family finding out, like Grace, the vignette that I shared earlier. And abortion care and contraceptive care can be violence prevention, because we can prevent people from being exposed to reproductive coercion from their families from unintended pregnancy. So I loved how we could all just interconnect all the topics that we talked about today. And just in terms of action points, as I wanted to reiterate again, destigmatize sexual and reproductive health in the community amongst health workers as well, and think about all of the structural issues around sexual and reproductive health. And we need to convince governments it's a good investment. So it's all about the money. So it's all about economic impact, gender equality, and that's how we can get them. I think that's an important lever, as we mentioned earlier.
Thank you so much. And as always, very considered and comprehensive. Let's go to Suha next. Any closing thoughts, reflections, call for action, anything?
So many things going on through my mind right now. I'm just absorbing everything. But I think, just to wrap up, it's really important to understand that reproductive coercion and abuse and other forms of, sexual and gender-based violence. It's really important that when we discuss these things and when we talk about these topics, that we do so in a way that does not marginalize already marginalized communities and compound the suffering of migrant and refugee women, and to focus on the dynamics of power that structure these relationships. And as far as things that we can do going forward, I think that, for one, we can start having more conversations about what reproductive coercion is, what sexual violence is, and foster these discussions in non-stigmatizing ways. We can advocate for more research and for more funding for services that provide support to migrant and refugee women, so that we know and understand and can respond in inclusive and safe ways.
Beautiful. Thank you, Suha.
Thank you.
That's terrific. And Jung, you get the last word. Do you want to have the last word?
For me, I really love the flow of our conversation. Dr. Shahi, I really love your data on the abortion. And when I saw the abortion care cost table and think about international students who got abortion, who have to do abortion in the first 12 months of arriving in Australia. And given that the students in Australia, research show that experience significant financial pressure, tuition fee, living costs are very expensive, and they have to pay with the cost of the table, abortion table cost you present is like really painful. And when Suha talked about reproductive coercion, I think with all my presentation, it's about systemic and structural barrier that with limited choice. So this is a reproductive coercion for international students who got pregnant or raising baby or had sexual violence and intimate partner violence as well. So so I think as I said in the recommendations, everyone should advocate for international students to have better access to the health services that they need when they stay studying in Australia.
Yeah. Thank you. I'm going to invite audience members to maybe put in the chat something they're taking away with them from today. And it might be feedback or something that really resonated for you. And I'm going to close with a quote that I really like. How does that sound? And we're even going to finish early. How amazing is that? That's. Does everyone like it when a meeting finishes earlier? Yeah. So in addition to thanking our speakers and our listeners today, I also wanted to say that if anyone wants to keep up with Multicultural Women's Health events, articles and work, sign up to their mailing list link via the chat. Whenever Multicultural Women's Health asks me to do anything, you know what my answer is? It's always yes, because I'm a big fan of theirs. So they do the best newsletters anywhere, like hands down, really thoughtful, considered analysis. And so if you want to read up about those beautiful connections Shahir was telling us between reproductive justice, sexual and reproductive health, and gender equality. The latest newsletter captures that really beautifully. And they're doing such good work. So I just really want to acknowledge all the people that are doing work in this space that have joined us today. Thank you for making the time to be here and to listen, because people can talk, but if there's no one listening and there's no one acting, then what's the point? So thank you for listening and being present and witnessing, and also perhaps thinking about your responsibilities now that you have this really important information. It's really made me think about perhaps the work that I can do in that destigmatizing kind of space, and non-marginalizing, how we can be strengths focused, how we can support the agency of people. I just wrote a million kind of notes, and so hopefully you've also written lots of notes, but also thought about what happens next in terms of your own development and your own work in this space. So I'm going to finish up with a quote. And you speakers, you're all stars. Can I join your fan club? Can I be your secretary? Can I join the queue? Please, please, please. You're all really awesome, and thank you for the incredible work you're doing, and please keep doing it. So I'm going to end with this quote, who's from one of my favorite feminists ever, and her name was Gloria Anzaldúa. And she said, or they said, "I'm participating in the creation of yet another culture, a new story to explain the world and our participation in it. A new value system with images and symbols that connect us to each other and to the planet. I'm hoping that this is what our conversation today has done for you and for all of us. Yeah, a new world, new language, new connections, new collaborations, new thinking. So thank you, everybody. Go well. Have a wonderful rest of the year. Keep warm in winter. And, I like to think I'm like Oprah. So I'm just going to say this. You're amazing, all of you. Keep it up. See ya.